to hear? Is anyone going to hear? Oh, they can from here. Oh, okay. Hi. Hi everyone. I'm Karen. I'm an F1 and I'm currently on paediatrics, and my first rotation was acute medical unit. So I'm going to talk about some common medical and surgical emergencies and use some real cases from the unit and then see how you can apply them to your OSCEs. So, when have you all got your OSCEs? May? Okay. And who's nervous about the OSCEs? Some of you look quite confident, like it. And who's more nervous about starting F1? Yeah, I thought so. Me too. I was absolutely terrified. But it's okay, I promise. Sort of. Okay. So, first of all, I'm going to talk about the OSCE structure, but not very much because I think you've heard all that before. And then about the basic approach to dealing with any emergency that you'll ever face, medical or surgical. And then talk about some cases that I've seen, and then we were going to do a quiz, but I don't think there'll be time, so I haven't done one. Okay, so apparently your OSCE is going to be over 2 days, is that right? And then you'll have like 13 stations, a day of 8 minutes and a day of 12 minutes. Yeah, okay. So if it's any similar to ours, we tended to be given a very short like précis at the beginning of what was going to happen, and then we'd go into a room and we'd have 8 minutes or 12 minutes to go through the scenario. So it was quite like a real life scenario, but then obviously rather than having to do the test yourself, you were handed the test. So I think an example I was given for you guys, someone came in with AF, what would you do? That kind of thing. Is that right? Yeah? Yeah? Okay. Okay. So I'm going to talk about common situations that you'll also see in F1 as well, because I think that would be really useful for you guys. Okay. And these are things that we'll have all seen already. So, the basic approach to all emergencies. I've been told that your medical school really likes the ABCDE approach, which is common sense and it's a really good way to go for it. So, have you people talked to you a lot about ABCDE? Yeah. Good. That's good, because you'll use it. So what I'm going to do, in that case, rather than just telling you, you guys can tell me. Okay. So, you obviously already know it's airway, breathing, circulation, disability, which is, we tend to use AVPU rather than GCS, glucose, and then everything else. So whenever we were faced with an emergency, or what we perceived to be an emergency, what surprised me was we have a lot more time than you think. There's no need to absolutely rush, obviously unless they're actually not breathing or the heart stopped, then you probably need to be a bit quicker. But otherwise, you just slow down and try and relax and just think about things slowly and logically, and you'd be amazed how much time you actually have. And even when the crash alarm goes, you've got quite a lot of time to think about things and think about what you're going to do. So, and an emergency typically might take, I think, I don't know about you, about an hour to deal with something, absolute minimum, to get everything done. So in your OSCEs, you'll run through everything in, I guess, super quick time because you're just saying what it is and it will feel very quick. But when you're faced with it on the wards, it takes absolutely ages, and a sick patient could actually take you all day. So A. So who's going to tell me about A? Yep. And if they haven't? Yep. And then if they were gargling a bit, you hear the gurgling noises? Yep. Excellent. Yeah. Okay. So, got to remember the C-spine. I've seen a couple of patients that, quite the elderly ones obviously are really osteoporotic, a lot of them, and I've seen a couple of people with unstable necks, so you do have to be quite careful. I've seen 2 in 4 months, unstable C-spines. Okay, and then as you said, like talking, I've got stridor, maintain the airway, and then consider adjuncts. So, you know what these ones are then? Someone else wants to say, yeah? Good, and these ones? LMA? Okay, and if you were on the ward and you heard someone gurgling and say they had a seizure, what airway would you choose to start off with? You could do? If you couldn't get into the mouth, or what else would you consider? What do you think? Yeah, these ones are pretty good, and they're quite easy. You know, do you know how to insert them? So yeah, up and then round. Okay, and then B. So someone else tell me about B. Your path. Would you? Would you really do it with the stethoscope to start off with? Well, you could do, but what? Yeah. So you spoke to them, and you can see from the end of the bed, like they're speaking, their airways clear, and they're fine. So first of all, you would be looking at them, wouldn't you? And you could see if their chest is moving. And what else would you look at? Yeah. Yeah. Exactly. Yeah. And when would you be really, 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 really concerned? When they're blue, pretty much is the case. Yeah, okay. So you do breathing, so you look at the respiratory rate as well, and like you said, you will obviously percuss and listen everywhere to make sure there's equal airway. Okay, what else would you do for breathing? Yep. What was that? Yeah, so you do the SATs as well, which obviously will tell you a lot. And do you know what SATs you're aiming for normal, if someone who's got no previous respiratory problems? What was that? Yeah. And what would you be aiming for if they have COPD but they've not known to retain before? Yeah. Because if you've got somebody, and I didn't know this before I started, but you often have people with COPD that'll come in and you actually deprive them of oxygen if you give them 88 to 92 to start off with, unless they're known to retain. So I would always start with higher unless you know that they're going to retain. And then you can always do ABGs and titrate it as they start to retrain, because otherwise they might be walking around and you're actually depriving them of some oxygen. Does that make sense? Does that make sense? Yeah, okay. Alright. So what would does everyone know about what the different oxygen supplements you use? So in absolute emergency, yeah, great. And if they have, and when would you consider ventilation? And don't just say when they're not breathing. Pardon? Yeah, you could do it, or when so I'd say when their respiratory rate's gone really low. Okay. Right. And you know about Venturis? Yeah. Does someone want to tell me what they range from, what percentages they range from? Yeah, great. So C. So someone else tell me about C. Yep. Yep. Excellent. Excellent. Sure. Okay. Did you mention ABG? I couldn't quite hear. It depends what his reason is. You can't just say it like that. Yeah. Excellent. I always forgot ABG to start off with. So. Okay. So as we said, so pulse, BP, cap refill, it's really important, like hydration status as well. Get IV access, because if you haven't got IV access, that's what they're all going to have a go at you for it, and it's really important. And then one thing we always forget is urine output. Because why are we measuring BP? Exactly, yeah. So if someone's got a really low BP, they're not perfusing the brain, so they'll be confused. But they also won't be perfusing their kidneys, which is why you get urine output. So you might also find that people run at quite a low BP anyway, but if they've got good urine output, and you can see that and you know that, and they seem fine and they're walking around fine, a low BP can actually be okay. But you would, as you said, think about fluid challenges. Do you all know about fluid challenges and what you do? Okay, we'll go through that anyway. And then D. So what would you do for D? Someone from this side, because you all look like you're going to fall asleep. So, yeah. Yep. Good. That's pretty much all the items. And pupils, you can think about pupils as well. Yeah. Yeah, you could do. You'll get, generally when you ask for the BP and the OBS, they'll give you everything anyway. So that kind of, the nurses will give you that, you'd hope they'll give that to you automatically as well, which is good, which is useful. Okay, so AVPU, what's A? Yeah, V, P, and U. Yeah, great, you know this. Okay. I've never done a GCS because I can't remember how to work it out. Can you? Unless it's 15 out of 15, can you? No, no one will do it. You need a big form, it takes about 5 minutes, and by that time they're probably conked out or something. Okay. E. What else would you do? What would you do for E? Sorry? Does someone from this side want to say E? Yeah, no, that's really good. And think about things like rashes, particularly in children. So, great. So everything else, like you said, whatever the case is. Okay. Right, so then so what I'm going to do now is going to run through some examples. I can't keep them to like 8 or 12 minutes exact with 50 of you here, as it would be with an OSCE. But I think these might be kind of similar to what you would get given in an OSCE. So what we had at HIMSS, I don't know about Leeds, we had a laminated piece of card outside the door. You'd have like a minute to read the piece of card, and it would say, give a scenario like I'm going to give you now, and then it'd say, we want you to do blah, blah, blah. So, or what would you do? So then the bell goes, we'll go into a door, and then we have 8 minutes or 12 minutes, however long the station was, to run through it. And they're not really expecting like genius answers, they're looking to make sure you're safe. So basically, as long you wouldn't just say, I'd do ABCDE, but you would run through logically, and as long as they could see that you're logical and sensible and safe and would ask for help when you need it, you'd be pretty much fine with the emergency stations. Was that the case for you guys in Leeds? Do you know? Yeah. Okay, fine. So, chest pain. So this was at the end of a night shift, and a 73-year-old lady, she was admitted to A&E via A&E to MAU, and she was waiting to be clerked. A&E she was known to have COPD. A&E had initiated management for infectious exacerbation of COPD, and the nurse looking after her said, could you come and see her? I know she's been waiting a while to be clerked, but her chest pain's getting worse, and I'm a bit worried about her. So what would you do? So someone here say what they would do first? Yeah? So ask for a bit more about, yeah, very good. Brief it, excellent. So you'd have a very quick look at the A&E notes to see what they'd started and what they thought, and see what was going on, and also because you'd hope they'd had an ECG as well. So this happened in our OSCEs as well, so we would get given an ECG and would say, so what do you think about this? So this is the closest one I could find to her actual ECG that isn't hers, from A&E. And what do you guys think? Does someone want to run quickly through what they think of this? Sorry? It's a little bit quick, yeah, and they are in sinus rhythm. What else would you look at? Do you all have like a logical sequence to go through it? So we already said that she's a little bit quick, and sinus rhythm. Axis isn't too bad. And then what do you guys tend to look at? if you're asked to see someone with chest pain, would you think about looking for ischemic changes on the ECG? Yeah. So what ischemic changes do you see on the ECG? Yep. What else? Not necessarily on this one. What would you see for ischemic changes on an ECG? Yep. Yep. So new bundle branch block. T-wave inversion is a good one. ST depression, ST elevation, and then if you've got Q waves, that means that they've had either they've fully infarcted now or they previously have done in the past. Okay. So on this lady's ECG, she had quite marked ST depression in the anterior leads. So and that wasn't actually mentioned in as she'd come up. So you'd be quite concerned about that because she's not been treated in A&E for an MI, and it's quite easily, things like this are quite easily missed. Okay. So now you know she's got chest pain and her ECG is a bit dodgy from A&E and she's been treated for COPD. Okay. So as we said, you do your ABCDE assessment. So she's talking to you. She has got some quite crackles on the right lower lobe and the sacs are a bit low. You're not too concerned about that. She's never been known to retain before, so it possibly is a bit low for her, but that's fine. Blood pressure is a bit low as well. You wouldn't really expect someone of that age to have a blood pressure quite that low because most of them have hypertension, and I don't think she was on any antihypertensives, and her heart rate's also gone quite quick. She was quite well hydrated and capillary refill was normal, so the first thing we did was obviously take a bit more history about this chest pain and do a repeat ECG. And so if I told you go over to her and she's clutching her chest like this, and say, oh, she's in agony, she looks really unwell. What's the first, and you've got that ECG, I mean, what are you going to think? Sorry? What? So, yeah, ACS. And what do you know on ACS it's not? So, well, you hope it's not anyway, yes. You'd hope it's not a STEMI, because the ECG so far didn't show that. So you're either thinking about unstable angina or an NSTEMI. And this is the kind of thing we got in OSCEs a lot, with a lot of ECGs. And in just a few stations, I got 3 different ECGs with this kind of changes. So that's why I wanted to use this as an example. So this is a repeat ECG. So what's changed? Obviously, it's 2 different people's ECGs because I couldn't find them. But what's changed? What's the big change on this? What do you think in the middle up there? Yeah, T-wave inversion. Okay. So all in, again, in sort of the anterior leads, and it was more here for her. Okay. So now you know she's got central chest pain. She's had ST depression initially, and now she's got T-wave inversion. So it's quite dynamic changes. So what are you really concerned about now? Yeah, she's having an NSTEMI. Okay. All right. So she's alert, but she's in severe pain. So what do you do now? Yeah. And how much morphine would you give her? You would. And what do you think would be a good start? Could do. Yeah. She's not that big, this lady. I haven't told you that, but she wasn't very big. So you can write in the prescription like 2 to 10 or something, and then and titrate to pain, and they'll do that. And what else would you do apart from morphine? Yeah, very good. And so you've she's got morphine, antiemetics. What else would you do? Would you give oxygen? Not really. What else is quite important? GTN, yeah. And then she says, oh, I've got some in my bag, I've got angina. So you tried the GTN and it still doesn't work, and it still hasn't alleviated the pain. The morphine's beginning to help, it's beginning to kick in, and it's getting resolved. So what would you do then? Yeah. And how much aspirin? Perfect. Okay. So She was actually on warfarin, so we weren't sure what to do, so we checked with cardio, and they actually recommended in this case not to give aspirin, but I wouldn't worry too much about that. And then once you can query lone rectal heparin and a beta blocker, and then we spoke to cardio. What do you think would be likely to happen to her for cardio? Someone said PCI. Yeah, she went for PCI, which I know you would have a PCI for STEMI, but you can have them for NSEMIs as well. Okay. So that was quite an easy one, I reckon. Yeah. So this one's acute shortness of breath. So she's a 48-year-old lady. She was admitted via the GP with a likely DVT. Whilst you're clerking her, so you're chatting to her, you're the F1 next year on the MAU, okay? You're doing the job that we were doing, and you're chatting away to her, and suddenly she gets really acute onset of breath, and you know she's got a DVT. What do you do? What would you do first? No. You're a doctor. So you're going to run through your... Yeah, so she's talking in full sentences, and she's got a respiratory rate 32, and she's got equal air entry, but she's really wheezy, and her sats are really low. So what are you thinking the problem is? Yeah, could be asthma. And what else would you be concerned about with sats that low and wheeziness? Yeah, PE. What else would you think? But you wouldn't get wheeziness with that, would you? What else? Pardon? So she's got crackles as well. Yeah, so you're thinking about infection. So you've got to think about possible asthma, VD, infection, and then you've also got to think about PE, because she's obviously respiratory rate's gone low. And you've got to think about other things as well, like pneumothorax or any other causes, but the most likely ones here are those three. So you go on to do C. So, and you'd have given her a nebulizer. You wouldn't go, if she was really wheezy like that, you obviously, you know, to treat that and then go back to wherever. Do you follow me? So you do your A, you do B, you find a problem with B, you treat B, and then you go back to A. So she's done A, B, C, and then her pulse rate's really high, but then that's probably because you've just given her a salbutamol nebulizer. You give her IV access, and then you do an ABG bloods, and the ECG shows normal sinus rhythm. Okay. And this is her ABG, so does someone want to run through the ABG? So when someone asks you to go to an ABG, it's best, has everyone got a structure? So what I do, rather than just like coming up with a diagnosis, I go, so pH, so what's the pH? Normal. What's the PO2? So you'd expect it to be high. What's the PCO2? Low. What's the bicarb doing? Fine. What's the base excess doing? So you know it's an acute thing. And what's the lactate doing? Yeah. So that would fit, as you said, with hyperventilation, but you need to sort of justify that, because if you just said that in the exam, I think that you might, I don't know, but you might lose points for not actually saying. So you could just quickly say, she's not acidotic, she's got high oxygen, but you'd expect that because she's on 15 litres O2, CO2 is low because she's breathing it off, but bicarb, base excess are fine, so you don't think it's acute, so sorry, you think it's acute, and the lactate's kind of normal, and you'd expect it to be going high up because you've already seen she's got crackles, so she might have an infection. Do you see how so I think that's more about, so you've got exactly the right answer, but you would, I think, in an exam you might lose points for not having your reasoning, because they want to see how you're thinking, possibly. I don't know. Okay. And she's alert and CBG. So differentials we've already talked about. So exacerbation of asthma, community-acquired pneumonia, PE, pneumothorax, PO, or anaphylaxis. Because she has had treatment initiated probably already somewhere along the lines, possibly in A&E. So you'd have to think about that too. So if she was really wheezy and low blood pressure, tachycardic, how would you differentiate between a PE and anaphylaxis? Yep. Well, how else? From like signs or symptoms. Yeah, exactly. So you'd have it. So you'd think about possibly looking for a rash or any angioedema or anything like that. I think it should be quite obvious. I think that's one of the few things I haven't seen yet, like with common emergencies. I mean, so investigations. So we've got portable chest X-ray that show consolidation, which fits in obviously with the exacerbation of asthma. White cells counts were high, neutrophils were high, CRP was reasonably high, 102, it's pretty high, and a PFR was less than 50 at best, but that's not possibly that helpful in an acute situation. That's more really for monitoring, but you could say that you would do that too. We did a troponin 12 hours later, and that was normal, and then the CTPA actually showed she didn't have a PE, and the Doppler did show she had a DVT, and blood cultures had no growth. So for her, it was infectious exacerbation of asthma, community-acquired pneumonia, and that just tipped her over the edge, and I think she got really emotional, really panicky, and started having an asthma attack basically. So, and she was fine afterwards. So another thing we get called loads and loads and loads is about, oh, so-and-so in bed 5 or whatever has got a low BP, or they've got their using at 6 or 7 or something. Okay, I didn't know that we'd get told to ask to see people with muses before. Did you? No, nor did I. And it's probably one of the most common things you'll get called to see. So I don't know if you'll have this in OSCE, but I thought it might just be good to see how you would go through it maybe. If that's useful. If it's too easy, just let me know. So you're asked to see an 82-year-old gentleman who's dropped his systolic BP to 82, and he has a news of 7, and that's because of his BP, his pulse rate's a bit high, and I think that was about it for him. So what would you do? You would? So you'd find out a little bit more than that. So the nurse is asking you to say, okay, so you're on call, it's an evening, you've never met the patient before, okay, and you don't know what he's been treated with or what's going on or anything about this patient, and you get asked to see him, because that is what will happen a lot on call. So, and you'll get bleached and it's over the phone, and then you need to prioritise because you're going to have to do loads of other jobs kind of at the same time as well. So you want to know, is this really bad because he's really ill, or has he been running at 90 for ages and he's just a little bit dry or something? So you need to try and find out a bit more information on the phone. So the nurse rings you up. So so-and-so's got news at the pulse of 7. What are you going to ask them? What are you going to ask the nurse? So? Yep. So low BP, high pulse rate. What else are you going to ask them? Okay, so it's been happening, looking at his chart, it's been happening maybe for about 6 hours, maybe. You just didn't really do much about it before and just let it go on a bit. But he was alright before, he's always been a bit low, maybe 120 systolic normally. What else? He's a bit off it really, he's got dementia, so can't tell much about him really. So will you come and see him? I can't remember, let me look at my slides. So he's been treated for a UTI and delirium secondary to infection. He's usually fairly fit and well, bit of dementia, bit of memory loss, but otherwise fine. He's got type 2 diabetes and he's tablet controlled with that. So you know that he's not going to be quite compos mentis anyway. So you do your ABCDE. So his patent, respiratory rate's not so bad, his equal air entries, that's fine. And his BP's low, his heart rate's regular, but it's really high, and his capillary refill's 3. So what are you going to do now? Pardon? Yeah, exactly. And how much would you give him? You know that he's pretty fit and well, and his heart's fine. Yeah, 500 is good. Yeah. So I would be quite happy to give him 500 mils if I knew his heart's all right. And then what do you do once you've done that? exactly, yeah. So then you get the obs as well. So if they had a bit of heart failure or AF and you weren't too sure, what would you do? Hmm? 250, did you say 250? Yeah, good. So that's pretty excellent. Has anyone got a time, by the way? Because I haven't got a watch on. 7:08. Oh, God, it's going quick. Okay. Yeah, exactly. Yeah. So you can do bloods, see if it's dehydrated, and you could do a CRP and do white blood cells and get some blood results to see basically what's going on. It would give you a really good idea. And if you responded really well to the fluid challenge, that would be really good as well. So I thought that was quite a simple one and quite a quick one, so you could get something realistically like that in a short OSCE scenario. Okay, so the drowsy patient. So you go to see a 31-year-old female. She's been in for 2 days. She was admitted with alcohol intoxication. She's on chlordiazepoxide reducing regime, and because she's had alcohol withdrawal, thought to be had alcohol withdrawal when she came in. And nurses say, "Oh, can you come and see her? She's really drowsy." What do you do? So you take a short, very quick history, look at her notes, and then do your ABCDE. Okay. So her airway's patent. She is replying to you. Respiratory rate's fine. Pulse rate was fine. BP is really high, but she's only responding to voice. She's not responding at all, really, apart from voice. And she's got pinpoint pupils. So what kind of things are you thinking about now? Pardon? Yeah? So you can think about opiates, yeah? What else? So I did, because obviously she's got alcohol intoxication. She's already on chlordiazepoxide, and she's got pinpoint pupils, so you certainly would think of opiates to start off with. But there's something else that you could think about as well that we didn't think of straight away. So what else would give you pinpoint pupils? So like raised intracranial pressure would give you pinpoint pupils as well, or it can do. So then you ask her a bit more about the history, and she says, "Oh, I was hit on the head by my friend when she was drunk, really hard, but that was 2 days ago." So you're thinking, and she's vomiting, she's been really drowsy since, and she's got a frontal headache. So I was still thinking, this is alcohol, or, you know, she's just had too many drugs or whatever, being very stereotypical and judgmental of me. But she has got really high BP, and she has got pinpoint pupils, so it's, what else would you do? Yeah, BT, okay. So you get IV access, blood, the platelets are 78, but otherwise they're okay. You check your medication to see if anything else is causing the drowsiness, and then you do an urgent CT head just to exclude a bleed. Okay. And then you get a call from radiology, and I hate calls from radiology, don't you? Because it just means they never want to speak to you, so if they do ring you up, it's bad. So they rang up, and she was having an intracerebral bleed, so. Okay. So it's just to try and demonstrate that you need to think quite widely about the differentials and not be too blinkered. So I doubt you'd get asked what to do beyond that, because, well, I didn't know. So I was just like having to phone the reg going, what do I do now? I've got no idea. So they put them on neuro-obs, which basically means the nurses are going to do they do the GCS properly, at least every hour, every half an hour. We're sent for an urgent MR angio, neurosurgery referral, and then because her platelets were a bit low and she's having neurosurgery, she's going to go for neuro, we had to transfuse her with platelets, and then she got admitted to the neuro HDU. So that's the kind of thing you might see. So another one was acute bleed. So another one is when the lab call you up, it's not good either. So they called you up to say that so-and-so, Mr. CH has come back and her INR's 15.7. So what kind of things would you do? You do your ABCDE, what else would you do? Pardon? Yeah, you would. And what? Lots of warfarin. Yeah, stuff for warfarin. Yeah, give vitamin K. Yeah. Yeah. Excellent. So you need to do all those things, but the fact is that her INR is really high, so you do want to assess the bleeding status. So LA was fine, B was fine, she's got IV access already, and it's quite important to repeat the INR because sometimes it is erroneous in the lab. Not very often, but I think we've seen it once when I was working on MAU. She was alert, she was really well. But she had got blood around her fingernails and her mouth, which I thought was a bit weird, but you couldn't see any bleeding anywhere else. And then you realise when you're talking to her, she's really confused. She's got no idea what's going on. So what do you think might happen? What might be causing the confusion? Could be a hemorrhage. Anything else? There's no one with her, you don't know anything about her, GP surgery was closed, and you can't get hold of the relatives, so you don't know anything about her. Did you say dementia? Yeah. So basically she turned out to have existing dementia and was so, unfortunately, had such bad memory, she kept on forgetting she was on the warfarin, so she just took loads and loads and loads of warfarin tablets. Do you all know about guidelines? They're really quite good guidelines at Leeds on the intranet. Do you ever look? I don't think you need to look at them yet necessarily, but do you? Do you know how to find them if you needed them? Are any of you going to work here? Yeah. So if you go on the intranet and look at the guidelines, they seem to cover almost everything. It's really good. So this is what it is. So basically, she had an INR greater than 8, and because we thought she might be having a major bleed on her head because you can't tell, we stopped the warfarin, we gave the IV vitamin K, and by the next day it was back to normal, the INR. It works really, really quickly, the vitamin K, it's really good. And this isn't her brain scan, but it was just to show you, is that subdural or extradural? Yeah. And so you see there's quite a lot in elderly patients with dementia. Okay. So I think I've got time for maybe one more, because it's really, yeah. Okay. So abdo pain, because I thought I'd try and get something vaguely surgical in. So I haven't seen that much surgery yet really, but this is a 35-year-old guy. He's got diffuse epigastric and periumbilical pain. He's been treated as gastritis and kept in overnight for observation, and the nurses ask you to write up some morphine because his pain's worse and it's not relieved by tramadol. So what strikes you as really weird about that? Start off with. The nurses are asking you to write up morphine for someone with gastritis. It's a bit excessive, isn't it? And the temptation to go, yeah, that's fine, is just massive. But I must have had a bit of spare time. So you go and review him, aren't you? You're going to go and review and find out why you need so much pain relief, because gastritis can be painful, but I would be quite surprised if it would be that painful. I don't know, you'll know more about that than me. I don't know. And then, so you assess him, his airway's patent, his respiratory rate's 14, it's all fine. Actually, he's really, really well. But when you examine him, he's got severe pain in his right iliac fossa. So what are you thinking now? It could be, couldn't it? You can't really exclude it, so what would you do? So what would you do? You think, oh, crap, he's got appendicitis and I'm tired, but I need to do something about it. Yeah, so you can make him nil by mouth. What else would you do? Did someone say get hold of the surgeons? Yeah. So you ring up the surgeons and say, please can you come and review my patient, blah blah blah, and what they're going to say to you. If you I haven't been told to fuck off yet, but it's not far off, I'm sure. I've been told in polite ways where to go. Yeah, so you're going to get IV access and you're going to send off the bloods they need. So what bloods would you send off for someone that you think might need surgery? Yeah. So FBC clotting is CRP, group and say is really important as well. Okay, and so on. So, and then they say, oh, well, do you think they might have perfed So you don't know, so they ask you for x-rays. So what x-rays would you do in someone with an acute abdomen? Yeah, and what you're looking for in a direct chest x-ray. Yeah, and then what else would you do? And abdo film, yeah, great. So that's what we did. And then that was just, but I think you all know that anyway. So, as I said, analgesia is already on loads. All of those bloods, don't forget the amylase. I forgot the amylase then as well. In case it's pancreatitis, you need to dip the urine, do a pregnancy test if they're female. We said about the x-rays, nil by mouth, IV fluids, and then you can refer, or you could refer once you've done the bloods and see what they want to do. And that was it really. Have I got time? No? Yeah? It's time? Do you want me to go through seizures really quickly? Yeah? Okay. Okay, so, right, the thing that surprised me the most about F1 so far is the amount of people that fake seizures. It's just absolutely unbelievable. And half of them have got epilepsy and half of them don't have epilepsy. And the ones that do have epilepsy, about half of those seem to be having pseudo seizures and real seizures. So it got really complicated and it was just really frustrating. So I thought it might be useful to go through this because no one said to me, you know when you have the lectures and they tell you about pseudo seizures and you think, oh, that can't happen that often. We must have seen it about once a week on average in 4 months. So it was really common. Okay, so this is a real example. So there's a 23-year-old, she's been stepped down from ICU following status epilepticus. So she is truly sick, truly poorly. The bedside alarm goes off and you're the first doctor there and she's having a tonic-clonic seizure. So what do? And you know all that history already, so you've got a good idea about her, really. Yeah, yeah, so that's good. So you've got to think about, safety, is she banging herself, or, what hazards are around and things like that. And you check the airway. So she's not speaking, she's making gurgling noises. What do? Pardon? So if someone's airway's not safe, what would you do? Yeah? So it's just a simple manoeuvre to make sure the airway's clear. And that worked in her, but in someone else it didn't. So we did some suction to get rid of the secretions, and then that worked. And you can obviously think about everything we talked about before. And their stats initially were at 93, so quite good air entry and no added sounds. And then repeat sats with oxygen as well were 94, so that was okay, so we weren't too concerned about that. And then I found though that during the placement that a good way to tell the difference, or one of the good ways to tell the difference, doesn't always follow, is that if someone's sats are absolutely fine during a seizure, they're known, say you knew they were sometimes had seizures and sometimes didn't, if their sats remain really good, and then you can do all the non-responsive things like lifting their hand up and landing it on their head, and I know you all know all about that kind of thing already, but getting their sats is really important, because if it's going down to 80 or lower, that's pretty hard to fake, although some people can do it apparently, but I struggle to believe that a little bit. Okay, so her sats were fine this time, and we got her hand, and then she wouldn't let go, and then you know to put the hand up in the air and let it drop, and if it drops in the face, that's could be real, and if it drops somewhere else, that's not real, because gravity just doesn't do that. Do you all know that kind of thing? No? Okay. Do you know does anyone know about pseudo seizures at all? Really? Well, I just absolutely had so many lectures on it, it was ridiculous, and I just thought they were talking rubbish. Okay, so pseudo seizures are people that are faking their seizures. Yeah, and a lot of it, people think it's because there's a deep psychological involvement that at childhood, people that were sexually assaulted as one way, and they have epilepsy, they knew that when they were having a seizure they weren't going to get assaulted. So the theory goes that some people would use a fake seizure to avoid being assaulted in some way, or to get out of the situation, whatever that situation might be. So that's become a coping mechanism for that person. And then some people will unfortunately fake seizures because they're so desperate for medical attention that they feel that's the only way they can get it. And we've had someone on the ward having a real seizure and then someone else starting to fake it because at the same time, because they think that will get them attention, and they don't know they're doing it. It's like a proper illness, but it's really, really difficult to treat, and you have to consider everything very seriously, and you have to send them to neuro, and they need to have EEGs and a full workup, and then only when they've seen a seizure and they've got an EEG and they know that they're not having a real true seizure, that's when you can call it seizures. And a lot of those people still get admitted, but you have to treat them obviously with a lot of respect and treat them exactly how you would do everyone else and make sure they're safe. And I found that the best way to do that was to make sure they have a good airway, make sure they've got their SATs. Even if they're faking, I would still always do their SATs, because you need to look after them and yourself and make sure they're not hurting themselves. Okay. And then another way I was told, which is a bit, you shouldn't really have to do this, okay, is that you can put pressure on their fingernail or pressure somewhere, or you could do this, but you're not really supposed to do this anymore. And if it's really painful, they will respond in some way, okay. You can't make voluntary movements if you're having a fake seizure either. So these are the ways of dealing with it, and I saw that far more than the other ones. So if you're not sure, do the SATs, and then if their SATs are really good and they seem really comfortable, you can leave them for like up to a few minutes, maybe 5 minutes, before you need to give them any definitive treatment. But if you're pretty certain they're having a seizure, then you can give it a lot sooner. Does that make sense? Yeah. Okay. So yeah, she was having a proper tonic-clonic seizure. So we put her in, you have to put them in a recovery position, and they'll be pretty out of it afterwards as well. Do you know how much lorazepam to give somebody? Yeah, I'd start with 1, and if they're really small, maybe even half, because I gave 2 to somebody and they didn't breathe very well afterwards. So I don't want you guys to make that mistake. So you can always give, but you can't take away. So you can give 1, see how and people do respond to 1 quite well. That's it really. So 1 to 2 milligrams, no response in a couple of minutes, you can repeat it. And then that was it, because I haven't got a quiz. Any questions? Is that useful? You don't have to lie, I don't mind if it's not. Okay, thank you. Oh, can you fill out the feedback forms, please? It's Karen Ball, B-A-L-L. You'll get this when you start. You'll have to do feedback forms to prove everything for your portfolio. So.